ladies and gentlemen, I think I wish that this evening I could only talk on my late friend, Professor Ramamurthi, the whole time, in order to bring to the awareness of the young people what it means to be born, to be educated by the family, at the school, and then later university. And when you have received some knowledge and you have some ability, what is your obligation, duty to the human being around you, in your country and around the world? And Professor Ramamurthi was one of the exceptional personality in this sense. But I think you are expecting that I should give a lecture. Otherwise, I would tell you probably those things that you know in the history of the city and of him. But I must tell you that his attention was focused always to the young generation. And you must imagine, as I become professor in the age of 33, and in 33 I was one of the founder of the neurosurgery in macrosurgery and peripheral nerve and skull base. And Professor Ramamurthi, in that time, it was 1971, I became professor. And immediately he has found that there is important that we become good friends. And I found him as he and his wife as well, a good friend, and we met each other from 1971, almost every year in different congresses. And we all wished at that time he will organize the World Federation meeting in India. He was the leading person of neurosurgery, representative of India around the world. And he had in every country several friends. They loved him. And finally, the World Congress, as we have heard, in 1989 was in Delhi. I was also there. And he organized a fantastic Congress. What I have felt as I came here and see the atmosphere, I think his spirit is among us. I see that his legend is not over. He has transferred that to next generation. And this atmosphere of Ramamurthi, I feel in this hall and with all of you. And this is a good example for many, many young people to know it is not enough to become professor in a field and then earn a lot of money and then die and say bye-bye, and nobody take care of you. It is important to leave something when you are going to the other world. Leave something, I would say, something that remains forever for the generations. And I am very happy that we had, together with him, very mutual ideas about the world, about young people. And until now, I can tell you, when the youngster student talk to me, if I don't answer him, I cannot sleep in the night because I am ashamed why a young person who are motivated, excited, and so and want to have some advice from me, I will refuse. No, I have no time, and I am in the other sky, and you should not touch me, and so. This is something that, unfortunately, I have experienced in so-called developed country. For me, developed country is not a developed country that has the best technology and best opportunities of the machines and also and whatever. Developed country is how the people of the country are developing their mind. And the mind for the society, and the mind for the world. We had just a meeting from one of my pupils, who is really one of my best pupils, K Sridhar in Mumbai, about complications in neurosurgery. They asked me to give some welcome address to the audience, and I said, 1 week ago, if you follow the news, more than, I don't know, how many hundred people, they met each other in Davos, in Switzerland, including more than 100 presidents of countries. They came there to talk about economy in the world and how we can trade with each other and solve the problems. But we had the meeting about complications, how we can avoid complications. I said, why these people don't go together and say how we can avoid war between the countries, how we can avoid a condition which is against peace in everyone, how we can help younger generation or generation in countries who have not the access for education, for universities, education. Now, and this is the dilemma we have today, and I must tell you something, and then I go to my lecture. Everybody who say, first me or first my country, they are enemy of human being in the world. Don't trust such people. India is very important, but if a politician here come out and said, first India, he is against if any of you. He is not defending your country. India or Germany, wherever, has a peaceful, wonderful condition when all others are also in good condition. We in Europe, we have not considered long time that over the water on the other side, Africa is suffering. And now, after thousands of African people as refugees died in the water and, now they are starting to think about that, what to do. And as I become world president in 1997, as you mentioned, the first action I had was we have make a statistic about our neurosurgery around the world. That is my duty as the world president. All country has nominated me as the president, and this is my duty. And as I heard that the entire Africa has only 74 neurosurgeons, I'm talking about Black Africa, I was really shocked. One neurosurgeon for around 7 million people. And then I started to create foundation, to create also educational center in Rabat and in many places. And in the meantime, we have also an Africa project. I am not going to talk about that, but I am also ambassador from the World Federation for whole Africa. And I have the African societies, they had 4 or 5 societies in different places. They were fighting against each other. Also the countries that are fighting because of economic situation or political situation. And one of my greatest achievements for Africa was that I took all the so-called president of these societies to me together, and I was talking to them. Every of them said, I am representative of Africa. So in the World Federation, I have to say something about Africa. The others said, I am. And there was all the time fight between them. And what I told them, look, nobody take you all seriously. Let us create a united Africa. And I invited them to Nairobi, and they came all. They were against each other, but as I invited, they came. And then I spoke, believe me, half an hour. My son was there, who is also professor for neurosurgery. He told me that that was the most emotional talk I have ever heard from you. Because I talked to their really inside, deepest place of their brain, to shake them, to wake up that they are wrong, they are doing something which is stupid. Finally, in Nairobi, in 2011, what was 12, I could unite them, and I told them, we create the first continental African Association of Neurosurgeons. And this is existing now, the third. And I, of course, in the second Congress they had in Cape Town, and they asked me, I have to go. I had to fly 25 hours to Australia, to South Africa. And then they made me as non-African, as honorary president of the African, of the continental, as the CAANs. And now they are growing together. And there are more than 50, 60 countries. They have every 2 years a meeting. And they are now, they have a position in World Federation, which is, I say, as strong as other continents. And they have representatives everywhere. And we are, of course, working for further education and further, I would say, facilities for Africa. And therefore, I must say, I am very, very involved how we can change the condition of neurosurgery, which is a very, very difficult field of surgery, so that everybody has access to the best options of treatment. And when we are in India, we know that it is due to many circumstances not so easy to provide every technological achievement to everybody. It is almost impossible. By 1.4 billion, is that correct? 1.4 billion. This is impossible that every department has an intraoperative MR or navigation system. But what I have done all the time, I did it in Latin America and also in many countries of Asia. I said, look, neurosurgery, to be absolutely perfect, for patient and safe doesn't need all technical advancement. It needs a brilliant and crystal brain of the surgeon to avoid nonsense in neurosurgery, but help the patient just with their hands and a few instruments. It is possible. One of the most difficult surgery, you know all, is acoustic neuronoma. It's not so easy. I need only 4 or 5 instruments, not more. And I can do the best surgery ever is possible in the world. So that I cannot say this patient has to die or whatever, so that every of you, and you have here a lot of people that have learned how to do it, they can do it with 4, 5, 6 instruments. But of course, there are other things that change a little bit the outcome in other processes, so that is dependent at a little bit. But I would say 90%, 80 to 90%, we don't need all these technologies that the people are talking about. And I am always very disappointed that some, I must say, some of colleagues, America or Europe less, but more America, they come to other countries that they have not access to, so, and then they demonstrate themselves with their equipment. But if you look at their presentation, for me is zero. Nothing inside of the presentation, but the equipment showing $10,000 or $5,000 this instrument and so, you know. And therefore I was not impressed by these people, and I was always talking about that in Latin America particularly. In 70s, 80s, I told to all my people that forget, if somebody come and start to talk about their whatever he has at home in operating theater, the man has no content, nothing inside of himself. He wants only to show up with instrument. Anyway, now I am going to talk about a field that neurosurgeons almost never talk about that, but it is my hobby. I am going to talk to you because some of you are not neurosurgeon, but I am sure every of you will understand what I am going to talk about. Have you ever seen someone with the paralysis of the face? Hanging the face down and is not able to close the eye? By eating the food and water coming down, by talking, you cannot talk normal because you have this facial palsy. Do you know what it means for a person in young age? Has to carry a facial palsy up to the end of his life? Do you know that these people avoid the society because when they meet someone, he looks only to the face of this patient about the face. Because with every mimic, you see these terrible changes of the face. That was something that as I was 25 years, 26, it hurt me. I say, I have to try everything what I can to help these people in any circumstances. And then I will now summarize how I started and at which places I was able whether to save. I have 2 parts of facial nerve. These 7 nerves has facial nerve. One part is preservation. Therefore, I am writing here preservation of the nerve. This is something I have done in more than 6,000 cases of tumors and processes which the nerve was engulfed in this with this tumor. And of course, when you remove the tumor and to sacrifice the facial nerve, the result is the face hanging, you know. So that this is also important to preserve the nerve in all neurosurgical operation. On the other side, if the nerve is damaged, how? Doesn't matter how we can restore that. This is something that I am going to show you, and that you take it with you home. When we look about the etiology of facial lesion, there are some unknown. For example, Bell palsy, when you have suddenly a hanging head. There are so many speculations. What is the reason of that? Is a virus? Is an allergy? Is whatever? This is fortunately a very little part. But tumors, the tumor, they can destroy the facial nerve, and the patient can have, or the hemorrhage. When you have a bleeding in the brain, it can destroy the nucleus of facial nerve, and you have a facial palsy, and also something else. Trauma, an accident. When the petrous bone is damaged, the facial nerve is running through the petrous bone, skull base, then you have facial palsy. They are malformations in children when they are born. And additionally, some vascular compression, they create hemifacial spasm, which is also worse, also for patients similar with the facial palsy. Of course, inflammation, but in our field, neurosurgery is the surgery, one of the cause of facial nerve palsy. And this is something that every neurosurgeon has to take into consideration and try to avoid. Where are the locations? In brain is the nucleus of the facial nerve, is the place intrapontine, and when there is a bleeding there or tumor there, you can have facial palsy. In petrous bone, and then in front, in front of stylomastoid foramen, at the end of the fallopian canal, and then parotid gland. There is, you know, there is a tumor of the parotid, and here this tumor, it is malignant, can create that also in face. So, what are the important information we need when we see someone come to you as doctors say, I have a facial palsy? What are? First is the diagnostic. You have to find where is the lesion. This is very important, because when we know where is the lesion and the rest of the nerve is intact, we can go make suture or take a graft, put between the two ends of the nerve. The other thing which is very important, is that complete or is it partial? Because the indication for surgery is completely different if it is partial. It is complete, then we have a clear knowledge what to do. And the other point is how long is this facial palsy? How long means when you have a facial palsy, or generally you have a paralysis in the arm, and then the muscles, they will slowly atrophy and change in fibrosis. So if the muscles are gone, You can reconstruct the facial nerve, but you don't get any movement. Then you have to do something else. And very important, therefore, to ask neurophysiologists to make electromyogram to find out if there is a spontaneous activity of muscle, that means is any muscle still present? Or the second one, the mixed innervation. We know, we have learned that from the other nerve, some nerves can grow to the other side. This can happen in childhood particularly, much more than the adult. And this question has to be answered. What you see here, the neurosurgeon immediately see it is a bleeding, intrapontine bleeding. It was a cavernoma. And what has the patient? Mostly they have a three sign. One is facial on the right side, and one is abducens. They are very close intrapontine together. That means the movement of the eye laterally is impossible. You can see it is going to the midline. And the other mostly come a little bit hemiparesis, also paresis of the arm. And what we have done in this case, of course, the first is to remove that hematoma. This is what you see here. That is intrapontine cavernoma and hematoma. And you can see we have removed this cavernoma, but you cannot replace the brain. There are some stupid people, they said, I take the stem cells and then I inject that there, and this will then create a new brain for you. There are so many criminal doctors, they are doing that in the world. Yes, but I cannot understand why they are not under pressure, or they have to spend their time in jail, not as in praxis as doctor. You know, this is. There are many such, because I receive every month at least 10, 20 emails. Professor, I have so many recommendations. I should take the embryonal things on stem cells, and I am paraplegic person for a spinal cord, or my brain is, they want to inject something. I tell that I know what is going on. Here it's impossible. Okay. We have started many years ago to take a part of other cranial nerve and bring it to the facial nerve to bring movement in the face. My first series was accessory nerve. Yeah. I published that also in the early 70s. I did it all in 60s and early 70s. I published, and the result was very good. But the patient need to move always to elevate the shoulder. It was not very convenient. Later, we have found that the nerve which is responsible for the tongue has almost similar function with the facial nerve. Then when we are talking, and so we are using facial and our tongue together. So we started to use the hypoglossus nerve and anastomose with facial. This is the technique, and I don't go to details. The neurosurgeon know that, but anyway. And this is the result. This lady, and the abducens, it is very easy. You need to shorten the lateral muscle in the eye. This is a routine operation by ophthalmologists. She has started to have a normal life after these surgery. But these patients, at that time, as we anastomose directly end to end, they had on one side atrophy of the tongue. But they could eat and they could use, as there was not a big handicap. But still, we try now in the last 15 years to change that. And now I will show you later, we have learned that if we do a side-to-end anastomosis of facial to hypoglossal nerve, but cut the hypoglossal nerve only 50%. 150% of the hypoglossal nerve can create a full function of the tongue without atrophy, and the other 50%, they make a fantastic function in the face. The next point is how we can preserve by tumors. I tell you the vestibular schwannomas, they are the majority of the cases, and fortunately, I have worked on that so much that almost tumors under 3 centimeters, my last publication is 100% the facial nerve is preserved. We unfortunately become tumors 5-6 centimeters. In that series, we have also 92% very good and about 7%, 5% good, but the other cases then needed than this hypoglossofacial anastomosis. For preserving the nerves, there are a lot of things that I have developed. We have to consider the internal auditory canal has to be open because the tumor goes with facial nerve in the bone. Here you can see. And then we have to respect one tissue, which is arachnoid membrane. And when we take the arachnoid membrane, then only dissect the arachnoid membrane from the tumor and not touch the nerve, then the nerve is very well preserved. I go to the end, you can see. This is the facial nerve. What you see here, you see how the nerve is sticking to the tumor. It's not so easy, but if all people who have been trained with me, they can do it. They have seen every day that I am doing that, and it is working. It is not only a theory. And that is the facial nerve, is you can see very well. You can separate facial nerve from the tumor, and you see we stimulate that brainstem, and the face is functioning. But there is, I say for neurosurgeon, one of my best recent in the last 15 years or so, discovery is the fat tissue. Do you know that fat has different cells? And I was talking about stem cells. Fat had also stem cells. And the fat, when you put the fat someplace, I do it in small pieces in order to fill the hole, to close, to avoid fistula and whatever. The fat tissue permanently, one cell of the fat die, but the stem cell, the next, they come and replace that. So if you have 20 different small fat together, I had a patient after many years, he had a recurrence in the internal auditory canal, and I had the fat. And as I opened, this fat was a united fat, I saw. That very clean, very nice, like a one unit. And the fat tissue will help the neurosurgeons. They're in many places. The whole spinal canal, the whole skull, and this is also a lecture for 3 hours. But you should not underestimate the meaning of the fat. You can see here this patient immediately after surgery. And here, even in such a large tumor, can you see this is really more than 6 centimeters? Yeah. Not necessarily you must have a facial palsy. Look, this boy, after complete removal, and has a wonderful face. Sometimes, when you must imagine this is the tumor, and the facial nerve is like an umbrella around this tumor. And you have to remove the tumor, and then in the same time you have to preserve. They are less than 1 millimeter, also every fiber, less. But they are distributed, also they are also not in one place. They are also through the slow growing, then it's like an umbrella. And they can some weakness, as you see here, immediately after surgery, but they recover. They recover very well. I will show you here in an Italian lady. I don't go, I want only at the end. This is a large tumor. Look, at the end, you see, the facial nerve is preserved and the tumor is completely removed. And you will see the patient had some beautiful lady, is a fat closed, the internal auditory canal is closed. That is a lady. You see the weakness on the right side. After 6 weeks, you will see no difference between right and left side here. That is the same lady. And therefore, important is I go to the patient and say, please, if you have a little bit weakness, don't worry. The nerve is preserved 100%, and it will recover. We cannot only recover, we can only not preserve the facial nerve, but also important is, in these cases, hearing. This is also a challenge of neuroscience. I don't talk about that today, but this is an example how the hearing has been here preserved. This is another case with preservation hearing and wonderful facial nerve. That was an Iranian doctor with very large tumor. You see the facial and also hearing preserved. That was a Korean boy, had bilateral on both sides. Can you imagine when such a patient on both sides, the face is hanging? They cannot eat, they cannot do anything. I had such patients from other countries, other clinics, that they had double side operated and double side facial palsy. I had to do something else done for them. I have operated, and then he had hearing loss on one side, and you see, I have operated, I have removed the tumor both sides. And you see, in one side, I have preserved also the hearing, and this is the patient. You see, can close the eye. On both sides, his facial is functioning, and on one side, hearing is preserved. You see, can close the eye on both sides.
오늘 하루 종일 너무 힘들었지.
Öffnen jetzt, Augen
입을 열어.
Augen
Soll weiter?
öffnen.
눈 열어라 이제. 눈 열어.
Und hier gucken.
그리고 여기 봐봐.
I show you that, this boy had the risk to have both side facial palsy and become completely deaf for the whole life. He can hear, and the facial nerve on both sides,
rechte Seite hört er nicht,
Ja, aber
links hört er.
left side hearing.
Ja.
Ja, er hört ganz gut.
Okay, ja.
So I don't go to these statistics, but when the nerve is interrupted, infiltrated, whatever happened, I started very early to take from leg the sural nerve a piece and put between the two ends of the nerve. And here, one example, you see the graft in between, and you see after 15 months, the symmetric position of the face. I have done, when you have, of course, from one side at the brainstem, you have the central stem of facial nerve, but you have not the distal stem in CPN. Then, in 1958, Norman Dodd, he has taken in 2-3 cases one long sural nerve from inside, brought outside, and here anastomosed with the facial nerve. I have in 1975 changed this, and I took the distal end in the bone and with a short graft and anastomosed them together. And it was working very well. This is my first case. This is, as you see, this is a stem at brainstem for facial nerve, and that is the graft, sural nerve from the leg. And the sural nerve then is through the dura taken out to the mastoidectomy here. That is the graft, and that is the facial nerve also anastomosed with them. And this is a patient with a complete facial palsy, and you can see 18 months later. That was my first case with this technique in 1975. How many years is that? Yeah, I have. This is, and you cannot imagine how excited I was when she came to my office and I could see her moving, and so she was the wife of a very famous architect. And that was, of course, this method became a routine also later. And then I have received many patients from many other countries or from Germany. This is a patient was operated somewhere else and acoustic normal. In this case, I spoke with her, let me go and see CP angle if the nerve I can find to end. She said, yes, we should try it. And you can see that that is also mastoidectomy to find the distal end. I found the central stem, and here, you can see here, in the bone, you have to learn it, how you open, and then you make a hole through the dura and take this sural nerve and bring the sural nerve between inside of the skull to the facial nerve, and that is the sural nerve. That is the neuroma, which was the central stem, and that is the facial nerve, as you see, and that is the graft. And the graft is adapted to the central stem, and I use fibrin glue. In the past, I made suture, but I don't do suture anymore. It's perfect tight, and then I go to the mastoid here. This is the facial nerve in the bone. Then I transect it and bring it to the side, and the other end of here, that is the second end of the graft, is then anastomosed to the facial nerve, and then another drop of fibrin glue over there, then the thing is set. And they are really, they make fantastic results we have had. And you see this is two holes, one in CP angle, one in the mastoid, and then the graft in between. Unfortunately, I show you how beautiful we can do it, but I will show you which disaster is existing today in the world by these tumors by young people, when they are operated by those people who have never learned how to do it. This lady came, I think, from, I don't know, 12, 15,000 kilometers to me in this condition. She was operated twice because of an acoustic neurinoma, and then irradiated with gamma knife. The tumor was growing still, and received for 1 year, because of hemiparesis, you see a facial palsy, steroid. And the steroid, a young, beautiful girl, became Cushing syndrome. And I said, I have now discovered a new syndrome, vestibular schwannoma Cushing syndrome. Yeah. And then I saw the tumor here with brainstem compression, and after gamma knife, and so, you know, it becomes not easier. Finally, of course, I have operated. And you see, the tumor was able to remove completely. And brainstem started a little bit to recover. Hemiparesis became also better. And 2 weeks later, I did the hypoglossophacial anastomosis. That is the facial nerve in front of foramen stellomastoid. This is the hypoglossus nerve. You can see the hypoglossus nerve. So, but I have to open the fallopian canal in order to cut the facial nerve higher, be able to bring it down to the hypoglossus nerve. And here, that is the facial nerve in the ball, and I cut it here, as you saw, and then I dissect and cut 50% of hypoglossus nerve, as you see here. In these cases, I make a suture because it is side to end, and then I give some fibrin glue. 2 sutures, lateral and medial, and then here you can see this video. This is the opening of the facial nerve in mastoid. You have seen also in the other. And now we transect it and bring it down. And now you can, yeah, that is the end of the facial nerve. And now you can see how far I transect the hypoglossus nerve. That is the hypoglossus nerve, this. So you see that 50% of the nerve is transected, and then here the anastomosis. And now the facial nerve is standing over the hypoglossus nerve like this, you can see. Okay, I operated, tumor was gone, hypoglossophacial anastomosis is done. 2 weeks later, and the patient went back to Chile, Santiago de Chile. 1.5 years later, I saw, under many patients, I saw this lady. I didn't recognize who is that, because it is not very similar to that what I have seen. But the face was perfectly symmetric, closure of eye was possible, tumor control was no recurrence, and here I put this together that you can compare at least the eyes with the eyes of this girl. It's the same. Everything else is changed, but the eye is still the same. And the tumor was gone, controlled, and here you can see the tongue. Now you can slowly. I will go. You see, as a movement, everything is possible, and yes, very good. And I show you now quickly the tongue. Yeah, here. Can you see? There is no atrophy. That is the beauty of this technique, which I am using now routinely for all patients who come from other places and have this. There is no options of facial nerve direct reconstruction. If possible, then I show you another example, which is very, very. This patient, young, 44 years old, operated in Europe, in a well-developed industrial country, in a capital city. Look at that. For this tumor, he received biopsy and cyst puncture. Everybody knows when you make a biopsy here on 6 patches, the tumor will grow. And then as they have a large cyst, they decided to do a cystoarachnoidal shunt. And then they used estrotactic, because the cyst was growing again, they did estrotactically puncture of the cyst. And finally, they put this man under gamma knife treatment. And as he came to us, believe me, he was not able to walk really. Very strong man, and so had an imbalance, vertigo, dysphagia, double vision in all directions, complete hearing loss, and also some facial palsy. And as he came, that was the condition as I saw this man in Hanover. Then, of course, we have operated, and the operation was so a lot of scar, because 2 times operate, 2-3 times with estrotactic and shunt. They opened and put shunt there, and was a lot of scar. The first action was to take the tube out. But I was not sure if the tube is hanging on the facial nerve or not, and therefore I had to deal with the shunt, with the tube, that nothing will destroy it through the tube. But you can see a strong, very strong, it was a very strong adhesion. I go quickly. Look, it was all the holes was closed by scars. And finally, we have, first, this baby was born. And then I started to remove the tumor. And the tumor completely we have removed. I go quickly. I had to open the internal auditory canal, and I show you only the end of the, here. Yeah. You can see the facial nerve also here under this tumor. And finally, the facial nerve we could preserve despite of enormous scar. Here, the tumor was finally completely removed. Yeah. Here. Now, complete removal of the tumor. This is possible, even in such a case. And then we closed that everything. This is the post-operative complete removal of the tumor. And this is another MRI, and this is the patient. Now, he came, recovered. It was 9 months after recovered without any deficit. Came to us, and the facial started to become better. Is it 9 months?
Hi, my name is Edwin Hagel. I used to have a tumor, a cystic tumor. I've had surgery in the Netherlands. First, I had one surgery. They made it substantially smaller. Then I had gamma knife. Unfortunately, after the gamma knife, it started to grow again. Around Christmas time, I came here at the ED, which is 9 months ago. I had surgery with full resection. The tumor is gone. All the cysts are gone. After the surgery, had a completely paralyzed right face, but they preserved the facial nerve. And now, after 9 months, hopefully you can see that it's substantially better now, and that I'm talking much better, and that my right side is not paralyzed anymore. So I'm Dr. Samii, extremely thankful for his great piece of art. Thank you very much.
Thank you. See here. And he came, here, you see, can close the eye. This is 9 months, yes. And,
Thank you very
but
much.
he came then after 1.5 years. Look, the facial with me. Perfectly recovered at all. But this is an example of 1,000 similar cases around the world. It's not only one case. I have published now a large paper about the collection of these. I wanted only to show you one example that you see it is not so simple that all these patients, fake acoustic neurinoma are removed, or everything is perfect. And trauma can create facial palsy. This is a child. You see this fracture of the petrous bone, and this baby has this, and this is also the same operation as you have seen. And this is another child, and you see on the right side the recovery. And I will skip this part because of time. In the trauma, in the mastoid, we can also make a graft. Here, this is a graft in the mastoid, and you see then the result. So is the patient before and so after. And here in the face, you can have a cut of the facial nerve, and we have reconstructed. And also in the facial nerve itself can be a tumor, then create the paresis. And this is, I have published several cases, several papers on that, and that is the classical MRI and CT of a facial nerve. This huge tumor was sent to me as acoustic neurinoma. But you can see the destruction of the petrous bone, and that was facial neurinoma. And you can see the bone, how much the bone is changed in the petrous bone. That is the girl with before operation. The facial tumor can create paresis. In acoustic, you don't have paresis before, but here. And you see that we have done a graft, removed the tumor completely and graft, and you see this girl about 1.5 years later with a fantastic face, and here closure of eye, tumor is removed and reconstructed. Another facial tumor which we have removed, and here is a tumor in the mastoidal course that was an opera singer, this lady, and we have reconstructed this, and she recovered very, very well, and you can see that closure of eye and everything, and she was able then to continue her life. I can also skip that. This is the so-called neurofibromatosis Recklinghausen. Recklinghausen, you can see in the face there are more than 50 tumors, but inclusive of facial nerve. And you can see I have removed all these tumors and then reconstructed with a sural nerve. And she recovered very well, but I operated in 70s at the University of Mainz, but she came 17 years later in Hanover to me and had such a Recklinghausen, you know, they can from each nerve start to grow. But interestingly, the graft for the facial nerve was changed also in tumor. That was very fascinating, you know. But I made a partial resection of the mandible and mandibulectomy, and then I tried to remove also, you see in the orbit, also we have also tumor here. And removed all these tumors, and again I did a reconstruction of the facial nerve. You can see here all the tumor I have removed in this case, and then you see the reconstruction of the facial nerve again in this case. In malignant tumor, you have to resect the tumor along with facial and or accessory nerve if you want to be radical. I have here reconstructed not only the dura of posterior fossa, but also reconstructed the facial nerve. That is the facial nerve reconstruction, and that is the accessory nerve reconstruction in the same time. Parotid gland, if it is a malignant tumor, you have to take the facial nerve as well, otherwise they will have recurrences. And in these cases, I took the distal end of the sural nerve, and you can see here the different branches for the facial nerve. And this is the patient after removal, and you can see the facial palsy and recovery after 1 year very well. This is a facial, this is a tumor, parotid gland, malignant, and the skin was also infiltrated. So that we have to do resection completely with the skin, and I had to make a rotating flap here. You can see this is the removal of the tumor completely, and you can see this rotation. You know, I did complete education of plastic surgery in my young age and become in Germany president of German Society for Plastic Surgery also, not only neurosurgery. Yeah, and you see yet this lady, how beautiful the face is recovered, and also the skin is not so bad, you know, so with a rotating flap. You know. And this is trauma, and again, here, facial palsy and the result. This is a very interesting case. In 1971, this girl was 19 years old, was a student. She heard about my activities for peripheral nerve, facial plexus, and so she came to my office. Professor, I say, you know what? I have this face, but since as I was 5 months old, as I was baby, I had a hemangioma here, and then I was operated and the hemangioma was removed, but from that time until now, 19 years, I have this facial pulse. Can you do something for me? I was, of course, very not so sure at that time, 71. 71 is also 48 years ago. You know? And I had experience already, but I didn't know. After 19 years, it is possible to recover. My Professor Sherman was the chairman of the Mainz, as I was his vice director. I spoke with him and said, I am so unhappy about this girl. And he said, why not you send all the patients for my electromyography? Why you don't send this girl, a student, to my... I said, okay, we have sent it. And I received the result, and the result showed that this girl has still a spontaneous activity in the things. And it shows there was some mixed innervation. Despite of it was no movement, nothing, not at all, but the muscle was still alive. Then I have decided to do the surgery. Look at that. I could find the central stem, I could find the different peripheral stem, and then I took the sural nerve and anastomose. And I was then waiting and waiting and waiting. Normally, after 9 months, you see the first movement and so, nothing. After 1 year, nothing. After 14 months, nothing. I say, it's not working. She came exactly after 18 months to me and then said, Professor, look, I can. It started just in a few weeks to move. Because of this postponed surgery, it took so, look at that. She was so happy, you know, that it becomes, of course, better and better and better and better. So that my advice, if you have a facial palsy, please, when they say 5 years ago, and so don't send this patient home. Send to neurophysiologist, but you must ask them, please answer me the following question. First of all, is there spontaneous activity in the muscle? Second, is there mixed innervation or not? Because they do sometimes some things and then say nothing and then send a finding that you cannot do any, make any decision. But these two questions. So another technique which we have also developed, it was not me the first time, but the Smiths and Scramella, they did it 1 year before. That was a facial cross anastomosis. That means when one side is intact, the other side is paresis. You can take a part of facial nerve on this side and under the skin take the sural nerve and bring it to the paralyzed side. This is what you can see here. It works, and here an example, but it is not so strong as hypoglossal nerve. And, but I have combined that with a muscle transfer. Lexer Rosenthal is the technique, and the things. You can see in this lady, I show from the temporal muscle, bring it here and bring under the eye. And at the same time, I use then the sural nerve. You can see immediately after surgery, the patient can, because of the muscle, can close, and because of elevating its symmetric position. But 1.5 years later, also the emotional movement came to that changes what we had. And here another example. I think the time is slowly, but is over, and I can continue more and more, but I don't want to go to the statistic of these cases. And I would like to close and to say that in this lecture, I wanted to bring the message to you. If you see a patient who has a facial nerve paresis, please tell him that in every case there is something to do, and send the patient to the right colleagues who has experience on this field. And I hope very much that the spirit of my late friend, Professor Ramamurthi, will continue not only in your generation, but also in other generations. They should always look back what he has done, not only for Madras and Chennai and for India, but for all the world. I thank you very much for invitation. Wish very nice evening.
Thank you, sir, for your illuminating, insightful, and edifying oration. Ladies and gentlemen, can we have a standing ovation?